When you get an ABG in front of you, sometimes you might get confused. Is it respiratory acidosis or metabolic acidosis? Or maybe respiratory alkalosis or metabolic alkalosis? And which is the primary disorder? Is this ABG a compensated or not? Or is there any kind of mixed disorder in this ABG? In this video, I'll be simplifying everything about the ABG in just 3 steps. And I'll be sharing 5 ABGs with you in this video, where I'll be interpreting, helping you understand how to actually go from step 1 to step 3, interpreting the ABG as a whole. The first 4 ABGs will help you build the foundation, and you'll learn exactly how to interpret ABGs step by step. And once you are confident with those, let's see if you can crack the 5th one, which is a bit tricky, a little confusing and an interesting one. And even some ICU doctors get confused by seeing this ABG. So stay with me till the end. So let's get started. ABG is an arterial blood gas analysis in which sample to be taken from arteries, and it tells mainly about the gases, that too carbon dioxide and oxygen. And this ABG predicts or tells you about the 3 important parameters in a patient. 1, the ventilation status with the help of PaCO2 levels. 2nd, oxygenation status with the help of PaO2 levels. And 3rd is the acid base. And in this video, I'll be talking in detail about the acid base. Now, before jumping on to the steps of interpretation or reading an ABG, we need to know the normal values or the normal range. First is pH, having a normal range from 7.35 to 7.45. And it just tells you about how your body is maintaining the equilibrium of acid and base, right? 2nd is PaCO2, which is partial pressure of carbon dioxide in arteries. The normal range is 35 to 45 millimeters of mercury. But in some countries like United Kingdom, we have the units in the terms of kP or kilopascals. Then this range becomes 4.7 to 6 kPa. 3rd, PaO2, that is the partial pressure of oxygen in the arteries. The normal range is 75 to 100 millimeters of mercury. In the UK units, it will be 10 to 13.3 kilopascals. Now, whenever you need to convert millimeters of mercury to kPa, always divide by 7.5 and you will get the answer, right? Now, the 4th one is bicarbonate, which is 24 plus minus 2, or you can say 22 to 26 milliequivalents per liter. So these are the normal values and the range. The acid and base in our body is maintained by 2 systems. One is the respiratory, or you can say the lungs. 2nd is the renal, or you can say the kidneys. Now, lungs, with the respiratory system, you can hyperventilate or hypoventilate, right? You can have CO2 washout or CO2 retention. Now, this CO2 acts as an acid because CO2 combines with H2O, forming H2CO3 and ultimately releasing H plus in the serum. Hence, remember, CO2 is an acid. Whenever it rises, it can cause acidosis. Whenever it decreases, it might lead to alkalosis. 2nd, if I talk about the renal system, it manages or maintains with the help of bicarbonate. Either it retains or it just secretes. Now, if the bicarb, which is the alkali agent, it just increases, obviously, patient can be in a scenario of alkalosis. Or if it decreases much, then yes, can go into acidosis. Why? The alkali is low, hence leading to acidosis situation. And you will get to know with the help of examples, which I'll be going forward in the next few minutes. Now, when you get an ABG in front of you, before interpreting, before reading the ABG, always try to have a brief clinical history of a patient, which might give you a clue that this might be the primary pathology or the disorder. Now, coming on to the very important part of this session are those 3 essential steps of interpreting the ABG. Step number 1 is check the pH. If pH is low, then it goes in favor of acidemia, which is acid in the blood, emia, right? But if you have a cause related to it, let's say there's a problem in the lungs or in the kidneys, then we call it as acidosis. But just to simplify, I'll be using the word acidosis over here. So pH low, it is acidosis. If pH is high, we'll call it as alkalosis. The normal range which I mentioned, before is 7.35 to 7.45, and we take an average of 7.40. So although, let's say, I give an example of pH of 7.38, although it is in the normal range, but it is going towards acidosis. Hence, remember, for the exam point of view, for interpretation, always consider it as acidosis, right? So that is how we have to. So we have to take 7.40 as the average. If any value is less than 7.40, acidosis. If value is more than 7.40, it is alkalosis. Now, coming on to the second step is finding out the primary pathology. If patient has acidosis, right, there can be only two possibilities or two causes. One, either increase the acid in the body in the form of PaCO2, or you decrease the alkali in the body, hence patient will go into acidosis. So decreasing alkali is decreasing the bicarb. So in the first instance, it is increasing PaCO2, hence causing and having a cause of respiratory or the lungs. So it is called as respiratory acidosis. Why? Because lungs are not able to hyperventilate. Lungs are not able to wash out the CO2. So if CO2 is retained, yes, that goes in favor of acidosis, and that too, the cause becomes respiratory. Whereas if I come on to the second cause, is decreased bicarbonate, which is either absorbed or secreted from the kidneys. Now, if bicarb is decreased, that means it is majorly lost. Hence, it will be called as metabolic, and the cause right now is kidneys. So second cause is metabolic acidosis if bicarbonate decreases. Now coming on to the second, which is alkalosis. If pH is on a higher side. Now this can happen only again because of two reasons. Either I decrease the acid in the body or I increase the alkali in the body. In the first instance, if I decrease the acid, right, or I decrease the PaCO2, I would say, that means patient is hyperventilating, patient is washing out. Hence, it will be called as respiratory alkalosis. The other scenario or the cause is increasing the bicarbonate in the body. Again, the renal systems are involved, or I can say metabolic. So now this becomes metabolic alkalosis. Coming on to the third step. This is about finding out is your body trying to compensate or not. Now, what is a compensatory mechanism in a body which God has provided to us is if anything rises, right, the other component also tries to rise so as to maintain the pH. Now, I'll just tell you in a form of example. If PaCO2 rises or acid rises in the body, the normal response or the defense mechanism or the compensatory mechanism is bicarb or alkali will also increase. Right? So remember, if acid will increase, bicarb will also increase so as to maintain pH in the range. Or the other way around, or vice versa, is if acid decreases, alkali decreases or the bicarb decreases. You can have all those examples, right? If I say bicarb increases, obviously PaCO2 will increase. So it is how the body pH is being maintained with these two systems, the lungs and the kidneys. And this is the chart for a compensation formula which we use, right, for different primary pathology. So first of all is you have to figure out the primary pathology and then whether the other system is able to compensate or not. Hence, with that information, we get to know is there any kind of mixed disorder or any other disorder associated or not, or maybe body is trying to compensate. And I'll be simplifying that with help of 5 examples. So don't worry, don't feel, oh, you are not able to understand. With those 5 examples, you will learn everything and be ready to be an ABG expert. So again, let's go on to those 5 examples. Interpret the ABG from this clinical scenario. Pause this video and read the history also the ABG provided and see are you able to come to the conclusion or not, and then resume the video. Okay, this patient presented with diarrhea, vomiting, has dehydration, signs of dehydration with hypertension, tachycardia, tachypnea, right? Now, this history says there is no respiratory or pulmonary involvement, and this goes more in favor of metabolic. Now, coming on to the interesting part is interpreting the ABG. We'll go with those 3 steps which we learned earlier. First, checking the pH. It is on a lower side. 7.31. Acidosis. Second step, finding the primary pathology. Now, acidosis can have two causes. Either you increase the PaCO2 or the acid in the body, or you decrease the alkali agent. Now, in this scenario, PaCO2 is just 29 millimeters mercury. It is low. It cannot cause acidosis. Hence, it is out. The other scenario, the cause could be decreased bicarbonate. And yes, patient has 15 milliequivalents per liter, which is significantly low. Hence, the primary pathology comes out to be metabolic acidosis. And whenever patient has metabolic acidosis, always calculate the anion gap, which is with this equation. Sodium plus potassium minus bicarbonate plus chloride. Some textbooks have removed this potassium and the normal range changes, right? So it's up to you. But if you have this equation, then the normal range of an anion gap is 10 to 14 milliequivalents per liter, or some books write as 10 to 16 milliequivalents per liter. And in this scenario, an anion gap is coming out to be normal. Hence, the primary pathology is normal anion gap metabolic acidosis. And these are the causes of NAGMA or normal anion gap metabolic acidosis. The mnemonic is hard as. Out of that, diarrhea and renal tubular acidosis or saline infusion is very important. On the other hand, if you talk about the causes of high anion gap metabolic acidosis, you can remember with the mnemonic mud piles. Over here, diabetic ketoacidosis and lactic acidosis are very important. Now we have done step 1 and step 2. Step 3 is calculate the compensation. Now in a case of metabolic acidosis, this is the equation, the Winter's formula. And we need to calculate how much is the expected PaCO2. So the formula is 1.5 into bicarb. First you need to multiply plus 8 and plus minus 2. Now if we put the values 1.5 into 15, the patient bicarb was 15, right? And then it comes out to be 22.5 plus 8 becomes 30.5 plus minus 2. That means the range is 28.5 to 32.5. This is the range which you expect patient to be having with that bicarbonate in a case of metabolic acidosis. And now if we check the actual patient PaCO2 which is given in the ABG is 29, and this is falling in the range. So this was expected and this is what the patient has. Hence, the respiratory component has appropriately compensated. That means this is what is expected by the lungs to work and get the PaCO2 in that range. Because I explained earlier also, if bicarb decreases, PaCO2 will also decrease so as to maintain the pH in the normal range. So this patient has normal anion gap metabolic acidosis with respiratory compensation. So this is what I will say. But if I say in totality, is this ABG a compensated one or a non-compensated or uncompensated? To give you the full answer, this ABG is partially compensated. I'll tell you why. Because there is a appropriate respiratory compensation done, but pH right now is out of the range. It is less than 7.35. Hence, we will call it as partially compensated metabolic acidosis with respiratory compensation. That is the full answer. Had it been the other scenario where pH has come in the range, that means let's suppose pH becomes 7.38, that comes in the range of 7.35 to 7.45, then I would have said it is a fully compensated. On the other hand, if your pH is outside the range and there is no respiratory compensation or there is no compensation from the other system, then it will be considered and it will be called as uncompensated ABG. Now coming on to the second scenario, patient presented in a similar manner having dehydrated signs and all those things and mainly presenting with the profuse vomiting. And this is the ABG. Kindly pause the video, try from your side and then resume. Now in this ABG, the pH is on a higher side, which is 7.48. Definitely the first step is alkalosis. Second, we have to find the disorder, primary disorder. Now, if there's alkalosis, there are two causes. Either there's decrease of PaCO2 or increase of bicarbonate. In this scenario, PaCO2 is mentioned as 47, hence cannot be a reason of alkalosis. And if you see the bicarb, yes, it is on a higher side. Patient bicarb is 32. Hence, the answer becomes, the primary disorder becomes metabolic alkalosis. Now coming on to the third step is calculating the compensation. Now using the formula, the Winter's formula, right? So this is expected PaCO2 is equal to 0.7 into bicarb plus 20 plus minus 5. And if we put the values in it, the range which comes out to be is 37.4 to 47.4 millimeters mercury. And this is expected PaCO2 from a patient. And if we see the ABG, patient's PaCO2 is 47. Hence it is lying in the range. That again says there is a compensation from the respiratory side. But if you see in totality the pH in this ABG is 7.48. Hence the final answer would be partially compensated metabolic alkalosis with respiratory compensation. If in your question they have provided just the option of fully compensated or uncompensated, I would say go ahead with uncompensated. Why? Because the pH is outside the range. I hope you are able to understand. Now I hope you are able to relate, right, as we have done first and the second scenario. Moving on to the next one, the third clinical scenario. Kindly pause the video, see the history and the ABG provided, and once you are done, resume. Now in this ABG, pH is on a higher side, 7.50, again goes in favor of alkalosis. So step 1 done. Step 2, finding the primary disorder. For alkalosis, there are two causes again. Either PaCO2 is low or bicarb is high. In this scenario, PaCO2 is 28, that is decreased. Hence, it can cause alkalosis. And if you see the bicarb, that is 22, the lower side of the normal range. Hence, it cannot cause alkalosis. So in this scenario, the primary disorder becomes respiratory alkalosis. And third step is calculating the compensation or checking the compensation. Now, before going into that, in respiratory scenarios, we have two causes or two scenarios. Either it can be acute or the chronic. The history says patient presented with anxiety, with palpitation, right? With that presentation of panic attack or anxiety, patient hyperventilates and there is a CO2 washout as in the case. PaCO2 has come down to 28. Hence, it's an acute scenario. So, we'll just use the formula for acute respiratory alkalosis, which says the expected bicarbonate, it decreases by 2 for every 10 decrease in PaCO2 levels. Now, in this scenario, PaCO2 is 28. We check from the average value of a PaCO2, which is 40. So 40 minus 28, that means the decrease in the PaCO2 is by 12 millimeters mercury. And for that, the decrease which is expected in the bicarbonate should be 2.4. Just using the binary equation, right? I mean, 10 decrease of PaCO2, the bicarb which is expected to decrease is 2. If the decrease in PaCO2 is 12, the bicarb which is expected to decrease should be 2.4, right? So 24 is the average of bicarb. So 24 minus 2.4. So it is again in the range. Hence, patient has appropriate metabolic compensation. And if you see the pH as a broader category, it is 7.50. That means it is out of the normal range. It is more than 7.45. Now, the summary, the crux, the final answer to this scenario or the ABG is partially compensated respiratory alkalosis with metabolic compensation. Clinical scenario 4. Now pause the video and again come back. Now in this ABG, we can see the pH is severely low, 7.18. Hence step number 1, it is acidosis. With that acidosis in the step 2, we have two causes, right? Either the PaCO2 should be very high or bicarb low. And in this patient, both scenarios are present. The PaCO2 is 52 high, hence yes, respiratory acidosis is possible. If you see the bicarb, that is also very low. It is 16, hence there is a metabolic acidosis also. So this patient has respiratory and metabolic acidosis. And if you see the stem or the history being provided, patient is initially presented with shortness of breath and now has decreased urine output. So respiratory system is involved, Now metabolic is involved and very commonly seen in sepsis, right? So patient presenting with, let's say, any infection, pneumonia, and further going into ARDS, so impairing the lung function and leading to AKI. So this is the scenario, and hence going into metabolic. So that's scenario 4, having mixed disorder, both acidosis present. Going to the next one, the clinical scenario 5. Pause the video, interpret by yourself, and then resume. Now in this ABG, pH is 7.48. It is on a higher side. Hence, the step 1 is alkalosis. Now with alkalosis, again, 2 reasons, 2 causes. Either PaCO2 decreases or bicarbonate increases. In this question, PaCO2 is 58, hence it cannot be the cause for alkalosis. Whereas the bicarb is 36, hence yes, it is the cause. The primary disorder comes out to be metabolic alkalosis. Step number 2 done. Third is compensation. If we apply the formula for metabolic alkalosis, it is 0.7 into bicarb plus 20 plus minus 5. And the value comes in the range of 40.2 to 50.2. But now here's the catch. This should be the expected PaCO2, but if we see the patient's PaCO2, it is pretty high. It is 58 millimeters mercury. That says in the patient, the PaCO2 is very high, as much it is expected. Hence, what we can say is patient having superimposed respiratory acidosis. I know this is somewhat confusing, that how acidosis can come when the pH is 7.48. But yes, this is what is a mixed disorder, and that is why I discussed as the last one, the 5th one, right? So try understand, try pausing, try rewinding it, coming back to it, that first we have to assess the primary disorder, which comes out to be metabolic alkalosis. Putting the value in that equation, it finally comes out to be in the range of PaCO2, which we expect from the patient is 40.2 to 50.2. But actually, in the ABG, patient has a PaCO2 of 58. Why? Because the history says there's a decreased respiratory effort of a patient, or the patient presented with shortness of breath, right? So with that kind of scenario, obviously, what you expect is patient is in metabolic alkalosis because of vomiting, and also because of respiratory drive, decreased respiratory drive, patient have retention of CO2 also. So that is what is collaborating and going with the history being provided, right? So I would just say the last answer for this ABG is uncompensated. Why? Because pH is more than 7.45. So uncompensated metabolic alkalosis with respiratory acidosis. So this is a mixed disorder again. So I hope you were able to understand. So these were the 5 important clinical scenarios, and always remember, if one component increases, acid increases, base also will increase, right? Forget about those formulas or mnemonics given, right, as Rome, respiratory opposite, metabolic equal. I mean, there's no point, right? No need of Rome, Italy, Paris, nothing. If you use the concept, if you understand what we discussed in this whole session, you'll be able to apply in any of the ABG provided throughout the world, right? And for the KPS, for those who are preparing for MRCP or PLAB, or who are working in the UK or countries where the unit used is kPa, obviously just try to change from millimeters mercury to the kPa, and then you are again there. Now, this is the question for you, the last, and just interpret, write in the comment section. And if you want me to upload another video of having just the question discussion, or maybe 5 more questions or 6 more questions, I can do that. So just write in the comment, first of all, the answer to this ABG, and if another video is required just for the question, just for practicing, do let me know. Bye-bye.